Today, we're going to break down a condition that millions, and I mean millions of people deal with every single day, GERD, or gastroesophageal reflux disease. But instead of just running through a list of dry facts, we're going to do something different. We're going to follow the real-world story of a patient, a guy named Frank Green, to see how this incredibly common problem gets diagnosed, and most importantly, how it gets managed.
And this, right here, is what it's all about. This is the heart of the problem for our patient, Frank. He's 52 years old, and this isn't just a little discomfort after a spicy meal. Now, this is a chronic pain that's so bad it's actually waking him up at night, literally robbing him of sleep. And that's often the tipping point, right? That's what turns what seems like a simple issue into a real quality of life problem that sends you to the doctor.
So here's our roadmap for today. We're going to start right where he did with his complaint. Then we'll get into what GERD actually is. After that, we'll walk through the whole assessment and diagnosis, see what the plan of action was, and check in on the results. And we'll wrap it all up with the key takeaways you really need to know.
All right, let's dive into the specifics of Frank's story. Now, on the surface, he's just coming in for a regular annual physical. But, as is so often the case, there's a bigger concern that's been bubbling under the surface for quite a while.
See, he's been trying to handle this heartburn thing on his own, with an over-the-counter drug. The problem is, it's just not cutting it anymore. In fact, things have gotten worse. He's now taking it every single night, and it's still not helping. And that, right there, is a huge red flag that something more significant is going on.
Okay, so to really get what's happening to Frank, we need to understand the condition itself. So what exactly is GERD, and why does it cause so much misery? Let's take a look.
In the simplest terms, GERD is basically a plumbing problem. All that highly acidic stuff in your stomach is designed to stay in your stomach. But with GERD, it flows backward, up, into the esophagus. And the thing is, the esophagus just isn't built to handle that kind of acid. That backflow is what causes all the irritation and the pain we call heartburn.
And here we can see the actual mechanics of it. So, at the bottom of your esophagus, there's this little ring of muscle called the LES. Think of it like a gatekeeper. Normally, it opens up to let food down and then it snaps shut nice and tight. But with GERD, that gatekeeper gets, a little lazy. It gets weak or relaxes when it's not supposed to, and that's what lets all that stomach acid splash back up where it doesn't belong.
So what makes that gatekeeper lazy? Well, it turns out a whole lot of things can contribute. Extra pressure on your abdomen, say from obesity or pregnancy, is a really big one. Certain foods and habits, like smoking or drinking a lot of coffee, can also cause that muscle to relax. And this is where Frank's story really starts to come into focus, because, as we'll see, his weight is probably a key factor here.
So how do you go from symptoms to an actual diagnosis? Well, healthcare professionals often use this really structured process called ADPIE. It stands for Assessment, Diagnosis, Planning, Implementation, and Evaluation. It's a fantastic framework, and we're going to follow it, starting with that first step, assessment.
Okay, so here's a quick snapshot of Frank's vitals from his visit. We see his height and weight, his blood pressure looks good, oxygen levels are fine, but the most important clue here comes directly from Frank himself. It's his report of heartburn kicking in about an hour after he eats. That is just a classic textbook sign of reflux. And then, boom. Right here, a huge piece of the puzzle just snaps into place. We take his height and weight and calculate his body mass index, or BMI. It comes out to 27.9. That officially puts him in the overweight category, which, as we just saw, is a major risk factor for GERD because all that extra weight puts more pressure on his stomach.
So, based on all of this information, we can put together what are called nursing diagnoses. These are basically the official problem statements. Number 1, he's got acute pain from the irritation. Number 2, his sleep is messed up. Number 3, he's at risk for actual damage to his esophagus. And 4, his nutrition is part of the problem. These statements are what will guide the entire plan of care.
Okay, we've identified the problems, we understand the science behind them, and we have the data. The next logical question is, what are we going to do about it?
Now, this is so important. A good plan isn't just about writing a prescription and sending the patient out the door. It's a two-pronged attack. You need the right medication, but you also have to empower the patient with the education they need to make real, meaningful lifestyle changes. First up, the medication. Frank is told to stop taking that cimetidine. It's what's called an H2RA. And while it does reduce acid, it just wasn't powerful enough for him. So he switched to pantoprazole, which is a proton pump inhibitor, or PPI. Think of it like this. His old med was just turning down the faucet on the acid.
A PPI goes straight to the source and shuts down the actual pumps that make the acid in the first place. It's a way more effective approach.
But pills alone are almost never the whole story. Frank is also given 4 key lifestyle interventions. First, he needs to figure out his trigger foods and avoid them. Second, stop eating at least 3 hours before bed. Third, use gravity to his advantage by propping up the head of his bed. And finally, and this is a big one, tackle the weight issue with help from a registered dietitian.
So the plan is in motion. Frank's been working on it. Now we get to fast forward 8 weeks to his follow-up appointment. This is the moment of truth. Did all of this actually work?
And the first piece of news is really great. It's a tangible success. By working with the dietitian and, actually sticking to the plan, Frank has already lost 4 pounds. Now, it might not sound like a huge number, but it's proof. It shows that the changes are working and that this is something he can actually do.
But this is the real home run. Remember why he came in? That pain that was waking him up every single night? It's practically gone. He's sleeping better, his quality of life is way up. The plan is absolutely working.
So, as we wrap up, what are the big lessons we can take away from Frank's journey? Let's do a quick recap of the essential principles for managing GERD the right way.
What Frank's story really shows is that managing GERD isn't a one-and-done thing. It's a whole package deal. It starts with a proper diagnosis, followed by the right medication, like a PPI. But, and this is a big but, the patient's commitment to those lifestyle changes is just as critical. And finally, you have to keep an eye on things, because untreated GERD can lead to much more serious problems down the road. It's this complete, structured approach that really works.
And this really brings us to a final, bigger question. We just walked through how this systematic, patient-focused process totally transformed the outcome for one person's GERD. So it gets you thinking, doesn't it? What if we applied this exact same structured approach to other chronic conditions, like diabetes or high blood pressure? How many more lives could we fundamentally change for the better?